We'll talk about some key abstracts in gynecologic oncology. Today I'm going to kind of summarize some of the high impact oral abstracts. I would say we're along the same lines as neuro-oncology this year in terms of kind of high impact abstracts. But we do have two recent FDA approvals that we'll review today as well, one in ovarian and one in cervical cancer. So we'll start out with ovarian cancer, and we'll go to first-line therapy. So there is still that question about neoadjuvant chemotherapy with an interval debulking surgery versus primary debulking surgery. We already have two clinical trials that demonstrated non-inferiority of neoadjuvant chemotherapy, and so I think there is that general trend across the country to do a little bit more neoadjuvant chemotherapy. Those trials show similar progression-free survival and overall survival, and neoadjuvant chemotherapy had shown that there was decreased OR times, decreased blood loss, decreased complications compared to neoadjuvant or compared to primary debulking surgery. But there's been a lot of debate regarding these two trials secondary to the patient population. So if we look closely at those trials, it was an elderly population. They were essentially a lot of patients where maybe the surgeon wasn't sure if they could make it through a primary debulking surgery, so they put them on these clinical trials. So the Japanese clinical oncology group tried to assess this question again. They also did a non-inferiority trial comparing neoadjuvant chemotherapy with interval debulking. What I would like to point out, though, is their trial's a little bit different in the sense that a patient would undergo primary debulking surgery. If they were not optimally debulked after chemotherapy, they had the opportunity to actually undergo a second surgery. The other difference is that in Japan, they actually get more chemotherapy, so they receive 8 cycles of carboplatin paclitaxel. In Europe and in the US, we tend to do 6. So there are some differences there. But if we go to the results and we look at overall survival, a couple things that I want to point out. I think if you can see here, if we do overall survival looking at just debulking, again, I think we've seen this time and time again. If you can debulk a patient to no residual disease, their survival is better, regardless if it's upfront with primary debulking surgery or whether it's neoadjuvant chemotherapy. You want to debulk them to no residual disease. But when we look at the overall numbers here, 49 months overall survival with primary debulking versus 44.3 months with neoadjuvant chemotherapy, it didn't meet their endpoint in terms of it is not non-inferior. In terms of progression-free survival, the progression-free survival was 15.1 months versus